Hello and welcome everybody to this episode on antimicrobial stewardship delivered to you in collaboration with the Commonwealth Pharmacists Association. I have my colleague here on the call, Claire, to support with the moderation. Welcome, Claire.
Good morning and good afternoon and good evening to friends and colleagues joining us from around the globe. Today is the fourth in a webinar series of 6, which the Commonwealth Pharmacists Association are running in partnership with the International Pharmaceutical Federation in response to the global issue of antimicrobial resistance. So today's session is focused on sharing experiences and examples of antimicrobial stewardship in the context of the community setting, where the majority of antimicrobials are supplied and used in human health. And I'm really excited to listen and learn from colleagues from around the world to discuss the diverse opportunities to support antimicrobial initiatives. My name's Claire Brandish, and I'm a hospital pharmacist in the UK by background, specialising in antimicrobials. And as Dahlia said, I'll be co-moderating this session. So thank you to Dahlia and Ali, who's working very hard in the background on tech support. I'm also fortunate to work for the Commonwealth Pharmacists Association as a senior AMR technical advisor. So for those of you who are perhaps less familiar with the CPA, I'm just going to briefly talk to you about this organisation. So the CPA is a charity that was set up in the 1970s with the goal of supporting and advocating the development of the pharmacy profession and the safe and effective use of medicines across the Commonwealth. The Commonwealth is a network of 56 independent countries who've signed up to a charter of shared values, committing to work together to create a better and fairer world for all the citizens of the Commonwealth and progress the Sustainable Development Goals. The Commonwealth encompasses about a third of the global population and some of the poorest nations of the world. Our mission as an organisation is to work in partnership and leverage the strengths of our network to support the development of the pharmacy profession through our relationships with national pharmaceutical associations of the Commonwealth. As many of you will be aware, lower and middle income countries are disproportionately affected by AMR, and this has become one of the areas of focus of our programmes of work over the last 4 years. Since 2018, the Commonwealth Pharmacists Association, in collaboration with our partners, the Tropical Health Education Trust, pioneered and ran Commonwealth Partnerships for Antimicrobial Stewardship programme. This involves partnering institutions in the UK with health institutions in 8 African Commonwealth countries to progress the national action plans for antimicrobial stewardship. The focus is to implement and improve AMS and IPC strategies. The programme is unique in the fact that it places an emphasis on the development of pharmacists as leaders in this sphere of work. And the success of the programmes has been largely down to the dedication of pharmacists both in the UK and in Africa and the multidisciplinary teams that they've worked with. The programme has not only seen direct benefits to the health systems and patients, but has also raised the profile of pharmacists in this space. I'm pleased to announce that the programme has reached phase 2, and we recently launched a call for applications for the next round of partnerships. So if you want more information, please look on the CPA website. The CPA have also delivered other programmes around antimicrobial stewardship, including the development and implementation of an app to increase accessibility of national guidelines across 22 lower and middle income countries. And countries have also been supported to collect data and bring about changes in practice around antimicrobial use and prescribing. The webinar series that you're part of today will culminate in a symposium during World Antimicrobial Awareness Week on the 23rd of November, where we hope you'll join us in showcasing some of your innovative tools and resources in tackling AMR in your own countries and regions, with the opportunity to further learn and inspire others. So please use the QR code to register your interest. This may be something that you've developed and implemented, or it may be an idea in the planning phase. We're delighted that FIP have asked us to lead this webinar series on AMS, recognising the work in this arena, and it's a great example to demonstrate the collaborative working between our 2 organisations who have so many shared goals. I'm privileged today to co-moderate with Dahlia Barges, who I will now hand over to.
Thank you so much, Claire. My name is Dalia Badison. At FIP, my role is lead for provision and partnerships, and I'm delighted to be co-moderating this brilliant upcoming session today with our colleagues and experts as speakers as well. I'd like to take a moment, please, if I may, just to introduce or reintroduce FIP to our listeners. FIP, the International Pharmaceutical Federation, is the global body representing pharmacy, pharmaceutical sciences, and pharmaceutical education. We have over 150 national organizations, academic institutional members, and individual members, and we represent, therefore, over 4 million pharmacists, pharmaceutical scientists, and pharmaceutical educators around the world. Our mission at FIP is to support global health by enabling the advancement of pharmaceutical practice, the sciences, and education. And our vision really is a world where everyone benefits from access to safe, effective, quality, and affordable medicines and health technologies, as well as from pharmaceutical care services provided by pharmacists in collaboration with other healthcare professionals. On the AMR and AMS agenda, FIP has been working on this area for many years. FIP's most recent position on AMR is set out in its 2017 Statement of Policy on the Control of Antimicrobial Resistance, and in line with the WHO-supported One Health approach that recognizes that health, or the health of humans, animals, and ecosystems, are interconnected, and agrees that this should be applied to measures to control AMR. The position statement called for governments to develop, fund, implement, monitor, and evaluate national action plans to contain AMR and formally involve all key stakeholders, including pharmacists. It also made clear FIP's continuing commitment to support to do the same. In 2020, I'd like to share and remind our listeners that the Federation launched 21 development goals to support the transformation of the pharmacy profession around the world. The FIP development goals, number 17, is antimicrobial stewardship. So a specific goal has been dedicated to advance the profession that focuses on AMR and AMS. And this shows how important this issue is to FIP and the pharmacy profession at wide. In the same year, FIP established the FIP Commission on AMR to explore and advance the solutions offered by the pharmacy profession to curb AMR across all settings and scopes of practice. The Commission's imminent AMR activities span education, policy, and public health, with related work in the area of vaccination and safety of medicines. They are in line with the FIP DG17 antimicrobial stewardship that I just mentioned. In addition, FIP, through the Commission, works on policy and advocacy on AMR, but does not do this alone, but it is in partnership indeed. FIP has also spearheaded a set of commitments that will be shared with our members on the first day of the World Antimicrobial Awareness Week, which starts on the 18th of November. Further really emphasizing and strengthening FIP's commitment in AMR reduction and the progress of AMS around the world. As Claire already mentioned, we are proud that CPA has partnered with FIP on this work, building on the huge legacy that CPA has in this area and in collaboration to address educational, training, and advocacy needs of our members and the wider profession, whether in the Commonwealth or elsewhere. As Claire already mentioned, this is the fourth session in a series of 6. Before we start, I'd like to run through some of the housekeeping items, please. I would like to remind us all that this webinar is being recorded and is live streamed via YouTube. The recording will be available on FIP and CPA websites. You may ask questions using the question box provided here. Kindly use the hashtag CPA Farm and hashtag FIP Digital Event while tweeting. We would really appreciate this to spread the word around. Become a member of FIP is of a great value to you all. And please do explore the option of membership on our website via fip.org/membership_registration that appears on your screen. So let me introduce you to the overarching outline of the program. We will be looking at using behavior change to help improve AMS in community pharmacy. That will be provided to us or covered by Dr. Amy Chan from New Zealand. We will look at pharmacists and AMS, engaging pharmacists in TB control program, which will be presented by Manjiri Garat from India. This will be followed by a look at cystic fibrosis story, combating AMR with treatments from Ella Balsata from the United States. This will be followed by a segment on experience on community facility linkage of multiple drug-resistant TB in Uganda by our colleague Tedio Tumasimi from Uganda, followed by the RBA initiative as a case study presented by our colleague Eric Vinante from Tanzania, and finally looking at train-the-trainer approach in enhancing the capacity of community health workers on antimicrobial stewardship in Wakiso district in Uganda, presented by our colleague David Musoke from Uganda. We hope that through this session, our participants would be able to define how pharmacists working in the community can support AMS and IPC initiatives as part of the wider multidisciplinary team, to be able to explain how different forms of education and awareness raising can support the AMR agenda in the community setting, to discuss learning opportunities for reducing the risks of AMR that can be harnessed from experiences in treating and managing other infectious diseases such as TB, malaria, and HIV. Describe how you can inspire and engage members of your community in a call to action on AMR, to demonstrate how AMR can impact patients at an individual, community, or a global level. And finally, that you may be able to apply some of behavior change techniques to improve AMS initiatives in community practice. Thank you so much. I'd like to hand back to my co-moderator, Claire, to introduce the first speaker and to run with the presentations. Thank you so much, Claire.
Thank you, Dalia. Wow, we have got an amazing lineup of speakers today. So without further ado, I'm going to introduce our first speaker, Amy Chan, who is a clinical academic pharmacist at the University of Auckland, New Zealand, and she's stayed up super late for us. So welcome, Amy. Thank you so much.
No worries. Thank you so much, Claire. It's my absolute pleasure to be able to share some of our expertise and experience around using behaviour change to improve antimicrobial use indeed around the world. And so as Claire had mentioned, and Dalia as well, one of the key things around good antimicrobial stewardship is being able to use behavior change techniques, because very much we know that antimicrobial resistance is driven by the behaviors of the end users as well as of the health professionals. So why is that, and why is it important that we look at antimicrobial resistance and behavior change? Well, firstly, let's have a look at the problem and the size of the problem. We know that antimicrobial resistance is often a cause of overprescribing of antibiotics, as well as an overuse of antibiotics in situations where they are not necessary. We know that sometimes this comes from patients being, prescribed antibiotics they do not need, or not finishing their treatment, or using leftover antibiotics as well. And we know this overuse of antibiotics and overconsumption is what fuels antimicrobial resistance. And there's been very much a campaign around the world to address antimicrobial resistance by reducing unnecessary antibiotic use, for example, for cold and flu. We also know that if not stopped, we know antimicrobial resistance can lead to about 10 million deaths by 2050 and cost over £66 trillion if it's not curbed. So as we know, it's very important to address antimicrobial resistance by ensuring optimal use of antibiotics, which is why pharmacists around the world hold such an important post in making sure antibiotics are not used unnecessarily, and the antibiotics are used under prescription and not shared, or leftovers aren't used. So just a reminder here, if we're looking at slide right, addressing behavior is really important for antimicrobial stewardship. So often the irrational use of antibiotics are actually driven by multiple factors. And this often just shows you that how the role of community as well as healthcare providers for this irrational use of antibiotics. And as I've touched on, this could be use of leftover antibiotics or overprescribing, as well as a lack of education for healthcare providers, as well as the quality of the patient and healthcare interaction. What I'll focus on today in terms of behavioral change principles specifically are two parts, is around the public lack of knowledge and awareness and the access to antibiotics as well, and the use of leftover antibiotics as a driver of antimicrobial resistance, or as well as pharmacists' knowledge, attitudes and beliefs. So what we did, some of our research is looking at public knowledge and beliefs relating to antibiotics and antimicrobial resistance around the world. And this is a sample mainly just to get views from around the world and looking at a sample of both high income and low income countries, as you can see depicted on the map. So we got responses from 250 responses around the world. And what we found is that the sources of antibiotics often that there is still a significant portion of patients that are receiving antibiotics outside of a medical setting. So whilst about 90% of respondents did get their antibiotics from a medical setting, around 10% of respondents still did not receive the antibiotics within a healthcare setting. So this is concerning as they don't get the advice that they need in terms of ensuring optimal antibiotic use. We also found in terms of non-medical sources of antibiotics that the most common source of antibiotics was use of leftover antibiotics from previous prescriptions or from other friends or family members. We also asked about antibiotic use in terms of, where antibiotics received on a prescription from the last prescription that they took. And what we found interestingly was that there was a significant difference between high and low middle income countries. So from low middle income countries, around 1 in 4 respondents said they took their last antibiotics without a prescription, whereas only 5% took their antibiotics without prescription from high income countries. And we also found that relatively more respondents also reported receiving antibiotics without any advice from low and middle income countries. So still quite a significant proportion of the public, around 1 in 4, are receiving antibiotics without getting any healthcare advice, which is clearly an area which we can make a big difference in. What we then looked at was whether any factors predict the public's perception or importance of and knowledge around antibiotic use and antimicrobial resistance. And what we found that was that age was a significant factor, that as age increased, the perceptions around the importance of resistance increase, which means that if you see a patient or a public that was older, they were much more likely to understand the importance of resistance compared to maybe a younger person coming into your pharmacy. And what's important is that as knowledge increases, so as we educate the public around resistance and around antibiotic use, then the perceptions or the perceptions of the importance or beliefs of the importance of resistance also increase, which highlights the importance of the role of education. Interestingly, importantly, is that country income classification does not predict the perceptions. So it means that regardless of whether the patient comes from a high or low middle income country, their beliefs or perceptions about the importance of resistance are not affected, which means that we can play a significant role in influencing the perceptions. So looking at these public beliefs, what we know is it's really important to be able to look at how to influence public perceptions about medicines. And what we know is that when it comes to beliefs about medicines, it really comes down to just 2 things which we can influence. Firstly is around necessity for action, and secondly is around concerns. So people are much more likely to believe that they need a medication and therefore seek medication if they believe they need it, compared to if they have concerns. So if they're concerned about harm about treatment, they're much less likely to seek the medication. And we can illustrate this in looking at people's thought processes. So often a lot of people will want antibiotics when they feel unwell because they perceive a high need of antibiotics. So they may be thinking that I really need antibiotics because I feel really unwell. Often they also have very low concerns about harm because often people do not perceive antibiotics as having side effects. For example, they may believe that there's no harm in taking antibiotics just in case. It's better to be safe than sorry. But actually what we want to do is move those beliefs and shift them to what we call optimal beliefs, which is to reduce the necessity for the antibiotics so that they believe they don't need antibiotics to get better, and also to highlight that unnecessary antibiotic use can lead to harm. So using antibiotics when I don't need them can be bad. So one thing that we want to do to bridge that gap is try and shift people towards a positive action. So information alone, we know, can't change behavior. And I'm sure we've all seen this. For example, we know we should be doing more exercise or sleeping more, but often knowing something is not possible to shift someone to guarantee appropriate action. So to shift someone to appropriate action, or is to guarantee appropriate antibiotic use in this case, is we must make sure that the information and the education that we give must concur with our existing beliefs, or must do something to change the beliefs, which is where behavior change comes in. So when it comes to looking at public expectations and demand, we know that the primary role for pharmacists to reduce these unnecessary antibiotic use is to be able to shift the public expectations and beliefs using behavioral intelligent messages. And we can do this by thinking about the consultation during that time and using behavior change theory. So one of the ways that we can do to make sure that our consultation stimulates appropriate behavior change is to think about how we construct the messages. So we want to make sure that when we give the messages, we are motivating the person to change their behavior rather than just giving information. And we want to counter any misplaced beliefs. So what we see, common sense default thinking. The common sense default thinking is when someone doesn't know much about a topic, or they have heard a lot of things, for example, from public media, and they resort to common sense default. What we can do in our education is address those common sense and say that it's often very common for people to think they need antibiotics, for example, when you're feeling unwell. But actually what science shows is that if you use antibiotics unnecessarily, it can actually do more harm than good. And that can counter any misplaced beliefs or any common beliefs that they have seen or heard. We also want to tell them a convincing story. So rather than just telling why they need to change, also making steps for and instructions for how to change their particular beliefs. So some of those things is giving them a couple of actions on how they can get better. For example, asking them to use non-pharmacological therapies around rest and fluid, keeping well hydrated, using pain relief rather than needing to use antibiotics to keep better, and making sure that they have a clear plan. For example, knowing that they can come back to the pharmacy in a few days if they don't get better, but that they don't need antibiotics at that moment, so they can overcome their expectations for antibiotics at that time. And we know that these work because we did a study looking at whether we can change these beliefs using a brief intervention. And what we did is we developed some of those messages and we delivered it to 100 people in an online environment. We gave these people a hypothetical scenario of cold and flu symptoms. And what we found is that if you give tailored messages, looking at people's beliefs and knowledge, and then giving messages to address any misconceptions, the way I mentioned in the previous scenario, is that we were able to shift the beliefs looking at their necessity, concerns, and their knowledge. And what we found is that over time, we were able to shift in about 75% of cases, that if you give these messages in this particular setting, 3 out of 4 individuals had a significant change in their beliefs in at least one domain. So at least 76% had a positive change in either their perceived need for the antibiotic, their concerns, or their knowledge about antibiotics and AMR, and this was significant across all parameters. So as we said, driving and looking at antibiotic use and making the most of those interactions in a community pharmacy setting is really important. The other thing is looking at pharmacist knowledge and beliefs. And what we did was a brief study also to look at pharmacist beliefs and how that may influence antibiotic supply. And this is important because recognizing your own beliefs can also affect your practice as well. And what we found was we actually surveyed around the world 546 pharmacists in 59 countries. And what we found is that, there was still a significant proportion of antibiotics being dispensed without a prescription. There's only about 3/4 were given in response to a script, but still there were a significant amount which dispensed antibiotics without a prescription. Importantly, what we found is that the greater the knowledge about antibiotics, the fewer the misperceptions. So very similar to the public, if pharmacists had a lot of knowledge about antibiotics, then they also held less misperceptions about resistance. And what we also found was that in a low and middle income setting, the beliefs about resistance tend to be scored lower. And there were many reasons for that. For example, because of the lack of regulation, perhaps in a low and middle income country, they also had less of a regulatory framework to uphold and some of those antibiotic practices. So it's much more difficult in a low and middle income setting to regulate antibiotic use. And interestingly, there was no relationship between work experience and beliefs, but the work setting seemed to affect beliefs about resistance. So hospital pharmacists seem to hold more positive beliefs about resistance. But this is important because having more positive beliefs, or if you yourself believe in the importance of resistance, you had a much lower odds of supplying antibiotics without a prescription. And as highlighted, I said the odds of supplying antibiotics without a prescription were 7 times higher in low and middle income countries than high in income countries. And as I said, that's likely because of the lack of regulation around around the supply of antibiotics, as well as a pressure often that business owners face in a community pharmacy to supply antibiotics to keep the repeat customers in that setting. And they felt that they had to supply the antibiotics in that particular setting. But neither knowledge nor work experience was associated with antibiotic supply without a prescription. So what this basically highlights is there is a significant role, because every time a pharmacist intervened, for example, if a patient didn't use leftover antibiotics, or they used non-pharmacological therapy, or didn't share antibiotics, or if they got good pharmacist advice, then that would prevent the spread of antimicrobial resistance. So there is a role that we can play at any point in time to ensure that antibiotics are used optimally. So I guess where to next? This is just a very brief overview of how we may be able to use, positive behavior change messages in our setting. But this highlights that little changes can have very big impacts, and all of us can play a role in antimicrobial stewardship. So it's important to choose wisely and make the most of each of your interactions. So I think in terms of contacting, there's my email and contact if you need to contact me. As Claire mentioned, because of the time zone, I might not be able to stay on for the questions because it will be after 1 a.m. at that time, but very welcome contact through email as well.
Thank you so much, Amy. I think you'll all agree that behaviour change is such an interesting and hopefully transformative technique in improving AMR awareness. I'm conscious of time, and thank you so much, Amy, for joining us. So we'll take questions in the chat box and we'll save these for the end, or we will forward these on to Amy if we're unable to address those in today's session and get back to you. So I'm now going to invite Manjiri Garat to speak. Manjiri is the principal for KM Kundnani Pharmacy Polytechnic in India, the Vice President for the Indian Pharmaceutical Association, and also Vice President for FIP. So I'm exhausted just reading your job titles, Manjiri. So the floor is yours. Thank you.
Thank you so much, Claire. And thanks to CPA and thanks to FIP for an opportunity to talk about the work which is very close to my heart. And I also bring greetings from Indian Pharmaceutical Association, as Claire told you, as well as from FIP's AMR Commission. So I'm going to tell you a story of our work in India of engaging the pharmacist in the National TB Control Program. And that's how we try to improve the adherence and try to reduce the impact of AMR. So let's go to the next slide. Can I have the control, Ali? Yeah. So as most of you know that India carries the highest burden of the TB across the globe. And we have more than 27% of this global burden in India. Approximately 2 million, yes, 2 million new cases we find each year. And half of that, 50% of that, those cases are of infectious TB, that is a pulmonary TB. Indian government tries to fight out with this situation with a national TB control program, which was earlier called as RATCP, now we call it NTEP, that is National TB Elimination Program. But for various reasons, because of various reasons, 50 to 60% of the patients try to go only to private sector than going to the government facilities. Actually, in government setup, there is free diagnosis, free counseling, free treatment throughout. But then people try to prefer the private sector. And therefore, in private sector, since there is no complete monitoring of the treatment, the non-adherence has been common. And as all of you know, there is rise in the cases of multi-drug resistant TB, even the extensively drug resistant TB across the globe, and more so in India. So also in India, we never had engaged a community pharmacist in any national health program. So this was so in around 2004. The next slide. Can I have the next slide? So in 2004, we took a courageous step because pharmacists in India were never involved in any public campaigns or in any public health activity. But with the support of, in fact, CPA and International Pharmaceutical Students Federation, IPA took the lead and we did a program of creating awareness about the TB in the community. We called it as TB Fact Card pilot project in Indian community pharmacists. And we enrolled pharmacists from Mumbai and an adjoining area, Navi Mumbai, that is New Bombay. And we did this project for 6 months. Now in this project, we realized, can we go to the next slide? We realized that there is a lot of non-adherence in the private sector. We focus this on the private sector. And there's a lot of non-adherence, and our pharmacists try to monitor the treatment as well as they try to improve the adherence by counseling, by contacting the patients, by going to their home. So this was like 6 months project, which was quite successful. From this project, we got an idea that it is important that pharmacists should be involved in the TB control program, that is the DOT. The next slide. Now, the government has, as I said, that there is a TB control program which provides everything free, and it is offered through the government facilities, public health facilities, primary healthcare centers, as well as through some of the shops, the private providers, the doctors, as well as some other shops. But pharmacies were never involved in this kind of the National Health Program and the DOT services. DOT stands for Directly Observed Treatment Short Course, which ensures that there is complete treatment adherence. So in this particular program, pharmacists were never involved, pharmacies were never involved. So retail pharmacies remained an untapped potential. From the CPA project, we realized that if we can engage the pharmacist in this DOTS initiative, then the patients can walk in the pharmacy and pharmacists can monitor the treatment. And that way we can ensure that the treatment is completed by the patients. So with this thought in mind, we moved forward and then we had several meetings because this was like, next slide, because this was like never before happened. And so this was the rationale behind our work, that the pharmacies are open for long hours. So patient can have benefit of advantage of walking into the pharmacy anytime to swallow the medicines instead of going to the public health facility, which may have very limited timings. And pharmacist patient, usually they have excellent relationship, friendly relationship. And if we can engage the pharmacies, it will also share the burden of the health system. So we thought to improve the access, equity, quality, and cost effectiveness of the TB services, it is important that the pharmacists be engaged in the DOTS program. So with this thought, with this rationale in mind, we move forward. And next slide. And we had several meetings with the stakeholders, because as I said, this was never happened before in the country, not in Mumbai, in country. So everybody had a lot of apprehension that whether pharmacists would be able to be DOT providers, whether they would take out time from their busy schedule, and whether there would be regulators also had a lot of concerns. But finally, we decided, all of them agreed to our request, and we decided to engage the pharmacists as a pilot in 2006. Then we conducted, next slide, please. Then we conducted training programs, and we tried to contact the pharmacists. We contacted like 25 pharmacists, only 7 turned up for the first training. So that's how we started. But we did start, and this was kind of a public-private partnership. So the government TB doctors were training the pharmacists, and we were there as a facilitator and to motivate the pharmacists. So we made a small beginning, but let me tell you, with a small beginning, we got a lot of good positive experience. Next slide. And next slide, yeah. So you can see one of these pharmacists here in the picture. Can we go to the back slide? A slide before? Yes. So this pharmacist was in an area where it was kind of urban slums, and many patients he could detect of TB. He could send them the patients who are walking in the pharmacy with TB symptoms, the TB suspects we can call. He was referring them to the government facility for the diagnosis, and the DOTS box, the DOT box of the entire 6 months treatment was then coming to the pharmacy if the patient was found to be TB positive. And then this pharmacist was monitoring the treatment. Patient was walking in the pharmacy every alternate day. That time it was alternate day treatment in India for DOTS, and then the patient's treatment was completed. So we got a lot of positive experience, and because of that, we decided, we got more encouraged, we got more confident, we decided to scale up this initiative. Next slide. And in 2010, with the support of FIP Farm Forum, IPA decided to scale this up as a 2-year project. Next slide, you can move on. Yeah. So the role of pharmacists was decided as the pharmacist creating the community awareness about the TB and the DOT program, referring the chest symptomatic cases to appropriate health facilities from the government, provision and monitoring of the DOT treatment to ensure the adherence, counseling of TB patients on medication usage, side effects, diet, etc., and rational use of antibiotics. So we decided, we devised a training module, and then we conducted the training programs. Next slide. We can just move on the slides. There are a lot of pictures. Yes, so this is the role of the pharmacist: referral, DOTS provision, and raising awareness. Next one. Yes, we can go to the next slide. So you can see this, some of these shops, you can see the pictures of the shops and the pharmacist in action. The patient walking in the pharmacy, pharmacist giving the TB medicine, and also offering a water, the glass of water, and making the records that the treatment has been given today. So like this kind of role was done by the pharmacist, and this was really a significant difference that made that was there in Mumbai and in India, because this was the first time pharmacists were doing something of this sort in India. Yeah. So yeah, everybody knows this is Amitabh Bachchan, the Big P, and he like his posters were put up in the pharmacy to attract the community, to tell them about what are the symptoms of TB, how the TB is curable, and how pharmacists can help them. Next slide. Yeah. So this is all statistics. You can have a look at the statistics. I can tell you at the end of the presentation the reference to this. And we had very positive experience. To around 200 pharmacists worked for this, and they referred several cases, and they completed the treatment of around 400 patients, and stopping them from developing into multi-drug resistant TB, and thus reducing the impact, thus reducing the AMR. Next slide. So there were no direct monetary incentives given to the pharmacists. Government does give small amount of honorarium to the pharmacist after completing the TB treatment of one patient, but basically pharmacists were involved because they were getting the satisfaction, and they knew TB is such a big public health problem for India, and they thought it would be really great that they're contributing. They also got the enhanced credibility because they were working with the government, the local government. So all this worked very well, and the pharmacists continued their work as dot provider. Next slide. So we ensured that we give a lot of visibility to the pharmacist work, and we give them recognition, felicitations, giving them opportunity to come to the conferences and felicitations. You can see a lot of pictures. So we ensured that they are motivated, they remain motivated, and they continue their work. Next one. Yes, next slide, please. Media, in fact, came to us and gave a lot of publicity, and this was really helpful because that spread the work in the community, in the public, that pharmacists are doing something for TB, and we can talk to the pharmacist and get help from the pharmacist. So this was like very helpful, the media publicity. Next slide. In fact, many people from other countries started contacting us thanks to FIP, because FIP gave a lot of opportunities to make this work visible through FIP conferences. And as an impact, Vietnam's government delegation came to Mumbai to see how pharmacists are involved in DOT program. You can see those pictures. Next one. Yes, so WHO gave an assignment to decide, to decide the roles of different stakeholders in such kind of public-private partnership. Next one. And we did so. We were more confident now. We were convinced that the pharmacists are definitely can be engaged in such type of TB program, and therefore we decided to do advocacy with the central government to engage the pharmacist in the national TB program as a formal route. Next slide. Yes, so WHO FIP joint statement released in Hyderabad, the FIP Congress in India in September 2011 helped us for making our advocacy much stronger. Next slide. And so you can see, as a result of this, central government Ministry of Health appreciated the work of pharmacists, and they on their own made an MOU with Indian Pharmaceutical Association and declared that the pharmacists are part of the National TB Health Program. Next. And so this is the training module, which is still on the website of Government of India's TB division. Next one. And this work, which was started in around 2006, still continues. Pharmacists still refer the cases, just symptomatic cases, to the government health facilities. You can see the FIP's community pharmacy section team visiting us in India in 2018 and appreciating the work of the pharmacist. Next one. Yes, so beginning, we made a very small beginning, very hesitant beginning. We were not sure what would be our results, but we knew TB is a big problem. MDR TB is a big problem, and we wanted to work towards it. We wanted to see how we can do something through the pharmacists, and therefore we took up this project, and which became kind of a practice later on. And so beginning with small number of 6 pharmacists in year 2006, we reached 3,000 plus pharmacists, and it is spreading all across India. Next slide. So we had a lot of learnings from this. I want to highlight one thing, that the pharmacist participation in the TB control program to increase the access to the treatment and to improve the treatment adherence is essential. We can do so. This can be replicated, and in fact, it has been replicated in some other countries also now. And this definitely reduces the possibility of drug-resistant TB cases, because pharmacists are there to monitor the treatment, to handhold the patient, and to walk through the treatment. So a small initiative ultimately can lead to the policy change if we are persistent enough and if we have patience and if we keep working. Thanks to all those pharmacists in the field who did great work, and they continue to do this work, and we are very proud of this kind of work which pharmacists do. National Pharmaceutical Association can play a significant role in public health program and can impact the policies. And pharmacists, we are convinced that pharmacists are a new pool of human resources for public health. And they should be engaged in not only TB control program, but many other national health programs. Next slide. So this is the, this is the publication of IPA, where the entire story has been told, which I told you in last 10 to 12 minutes, but you can see this. This is on the website, ipapharma.org. And you can see this entire project over here. Next one. Next slide. Yes. So thank you very much. And thanks again for the opportunity.
Wow, thank you so much, Manjiri. This is so impressive and inspiring. I think the one message that I'm certainly taking away from the presenters today is to just start with your ideas, no matter how small, because you never know where this is going to lead to. And actually, this is just so impressive to see. So thank you. We're going to change tack slightly at the moment. We're going to listen to a patient advocate, Ella Balassa, and her very personal story of dealing with AMR. So we're going to play a video now because Ella's unfortunately not able to join us. And any questions for Ella, we can direct to her after the webinar today. Thanks, Ali.
Good morning, everyone. I'd like to give a thank you to Vanessa for inviting me to share my patient experience with you today. My name is Ella Balassa, and I'm a patient with cystic fibrosis and someone who has over the years become an advocate for myself, the cystic fibrosis community, and more broadly as a representative of patient communities who need support and collaboration from all healthcare stakeholders to improve quality of life. So to give a little more context into my daily medication and treatment requirements, these are the pills that I take daily for my CF care. As I said, I do breathing treatments 4 times a day, always using albuterol, that vial there on the left side, to open the airways. Hypertonic saline helps me cough out the mucus. Pulmozyme thins the secretions, and I do this once a day. And then the last vial may look unfamiliar. This is a treatment called phage therapy, which I have done a few courses of in the last few years, and I'm going to talk a little bit more about that later on. And then with the pills, you can see a number of vitamins and supplements. Since I don't digest food properly due to a defect in the pancreas with CF, so I need to take enzymes to help absorb the food, and many of the nutrients from foods I don't digest, and so I need extra vitamins and supplements. And I often also take oral antibiotics. You can see doxycycline, but I'm often on Cipro, Levaquin, amoxicillin, Bactrim. And in the last 2 years, I have also been on a medication that treats the underlying cause of CF, which I have been very grateful to have. And this is called Trikafta. And it has stabilized my lungs. Day to day, I have less mucus production than before. And I found relief for a few more hours between breathing treatments. And I've gained a few extra pounds. And this treatment is the 3rd approved drug to treat the most common genetic variation of the CF mutation. And it is potentially useful for nearly 90% of the CF population. So this is, I received an experimental therapy, and I found out about this accidentally through watching a documentary online about another patient with CF who was treated. And briefly, this is called phage therapy, and it uses a specialized virus that has a specific host range. Similar to antibiotics, these viruses bind to bacteria, but unlike antibiotics, which are small molecules and that inhibit bacterial replication, phages inject their own DNA into a bacteria, and then it causes the bacteria to start replicating more of the phage inside of itself until the bacteria dies, bursts and dies. So over the past few years, I had been dealing with more difficult to treat lung infections. And I've been looking for alternatives for treatments, but there was nothing except traditional antibiotics, which I've used many, many times over again. And they over time become less effective in treating these infections due to antibiotic resistance. So in 2019, right around the time of finding out about phage therapy, I was very sick with a pulmonary exacerbation with an infection. I was on oxygen all the time. My lung function was about 18%. I, at that point, had been on 5 weeks of very strong IV antibiotics, and they were not helping to clear the infection that I had. And so when I saw that documentary about another patient being treated, I communicated and contacted the researchers directly, and I inquired whether I could potentially be treated as well. And having those conversations with them, I also did a lot of my own research to find out more about it. And phage has actually been around since 1915, mostly abandoned after the discovery of penicillin, which could be commercially manufactured with ease. But phages have still been utilized in Eastern Europe. And there is now, a rise of renewed interest in phage because of the rise of antibiotic resistance. So I was really scared, to be honest, to try this treatment because it's experimental. There's not a lot of research on it in the recent past. And at the time, because I was in such a very vulnerable state, so sick with that infection, I just didn't know what would happen with my body. Nonetheless, I weighed the risk benefit and decided I was going to try it. And so I traveled to Yale in January of 19 to receive this treatment. You can see in the photo there on the right, I was inhaling this treatment mixed with normal saline, and did that for about a week. And then about a week after my treatment, I began expelling those dead bacteria from my lungs from the infection. And I never cleared an infection so quickly before. So I knew it couldn't be just the antibiotics that I was using, but it had to have been the phage working in synergy as well. So I definitely consider phage to have been successful in clearing that acute infection. And navigating that treatment myself, really without the guidance and help of my cystic fibrosis physician, it made me realize that if I wasn't equipped with the understanding and the prior experience communicating with the research community, I wouldn't have been able to access this, and my life could be very different now. So I wanted to share about this experience to increase visibility for a viable alternative, for patients that face resistant infections, and to promote self-empowerment to others to take on these roles in their own care. So I wrote about this experience in the HuffPost, and that's where that screenshot is from. And sharing my story really piqued the interest in the CF community, and I began being invited to share my story more publicly. And so this was the beginning of, as I said, sharing my journey on the public stage at phage conferences, AMR congressional meetings, webinars. I aim to bring awareness to this growing problem, to encourage and inspire the research community to pursue new viable alternatives, encourage multi-stakeholder collaboration for new innovation, funding, and better patient health. Because antibiotic resistance is a significant health crisis for the global population, and I feel empowered to raise awareness and to bring research advancement to truly a dire issue. So these are just some screenshots of some of the platforms that I've advocated through. I've been featured in a couple of articles in Nature and New Statesman, and conferences and meetings through Sepsis Alliance, the Infectious Disease Society of America, Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria, and have been a part of a few documentaries, one being the BBC StoryWorks. And I really will continue to advocate for a future where antimicrobial resistance isn't the greatest threat, to my life and to many others' lives. So I've shared a lot about my own health journey and my advocacy journey, but I want to focus a little bit on how patients can be empowered by their care teams, which includes pharmacists such as yourselves, to be, to some degree, these active participants in their own care. So how can you support patients in their health and their journeys? Well, we know that patients rely heavily on guidance from their healthcare professionals across disease communities, and they obtain a lot of their information about their health status from doctors. They receive support and information about health resources from social workers. They gain understanding about their medications and treatments regimens from pharmacists. So it's really important to build this strong foundation between care teams and patients to improve upon the relationship. And this really should be based on that open communication, dialogue, and respect. And so even though it may not seem like pharmacists' role is directly tied to patient hands-on care, but you are still very much a part of the ecosystem of providing the support and learning about the patient to build that relationship and achieve better treatment adherence and understanding about medications. I'll share a brief story where a pharmacist's role was actually critical to my care and potentially saved me from a dangerous situation. I was starting a regimen of home intravenous antibiotics, and I had been in the hospital prior to that. And before I left, I was visited by the pharmacist to go over how I would be dosing the medication, with a demonstration from mixing the solution to connecting the tubing. And I was shown the name of the medication and what the administration vial would look like. And so when I got home and I got the shipment delivered to me, I opened it up and I saw that it looked slightly different. And then upon closer inspection, it was a different medication than what I had been shown in the hospital. And it had another patient's name on it. So I immediately called the pharmacy and they had the right medication sent. But if I wouldn't have gotten that hands-on tutorial and training and the time spent with me in making sure that I knew what medication was going to be coming and how it looked, I could have been infusing a chemotherapy for all I knew. So, making sure the understanding is there for patients and asking them questions to verify this about their treatment and their care is really important. And to do this, leading with empathy is the most important thing to have at the forefront of these interactions and these discussions with patients. And it must be at the root of all healthcare interactions. So when it's a doctor or a pharmacist communicating with the patient, empathy makes you, as the care provider, slow down and take the time to explain a new procedure or a new medication. Think about this. At one point in all of our lives, we will most likely be a patient in some capacity, and everyone wants to be treated with authenticity, with compassion and care. So let's make sure we're keeping that at the center of all that we do for patient care. And the last thing I'm going to leave you with is my lung drawing. Outside of my advocacy passion, I also have an interest in sharing my voice through art. So a few years ago, I decided to draw this piece as a tribute to all those that have lost their battle with CF, and that their roses continue to bloom through the way that they have impacted our lives. And it's a symbol for all of us that still fight the disease, that we can take on each day with a smile and, strive to never take a moment for granted. So it's hard to read the text down below the photo, but it says the branches are in the shape of lungs stemming from the main bronchi, and the roses, not only being symbols of CF, are also symbols of the flourishing life in lungs stricken with illness. And despite the dead and dying tissue of scarred lungs from infection, there's still beautiful life within each person that has CF. And our roses bloom with each battle we face and win, to live to enjoy the next day and appreciate all that it has to offer. So as I kind of said at the beginning of the presentation, CF is my greatest blessing and the greatest curse. It affects me daily, but does provide a lot of inspiration. So that's it for my presentation. Thank you for having me, and I'm looking forward to the Q&A. Here's also my contact information, and feel free to reach out to me. Thank you.
So I'm very grateful to Ella for taking the time to share her very personal insights and experiences in navigating this very real problem of AMR in her everyday life with us. This is an area I have no experience of, but really interesting times lie ahead as we expand into new territories, and hopefully this brings hope with it. Next up is Taddeo Tumasini. He is a programs coordinator at the AIDS Information Centre and a Master of Public Health student at Nakiri University School of Public Health in Uganda. So over to you, Taddeo. Thank you.
Thank you very much. I take the pleasure to take you through my personal experience as far as multiple drug resistant TB is concerned. Looking at an experience ranging from right from year 2011. We can go to the next slide. Yes, I started this journey in 2011 as a volunteer in TB work at the Makinde Division, Kampala, around susceptible TB, which isn't really not resistant to TB medicines. And what prompted me to join the fight was that over 300 MDR at national level. And what caused this, there was no medicines that would treat multiple drug resistant TB in the country then. And for a few advantages, could afford buy a few medicines, but these were highly expensive and they had to go through a very complex import mechanism. So around 2012, we got some medicines through some project, and treatment was rolled out to accommodate only those, at first, those who could be managed in terms of isolation at the treatment center. But also at the same time, we had a health worker shortage. So that was another problem at country level. So later on, in 2013, after, of course, just a year of rollout, there emerged another problem of the so-called difficult patients who are characterized by refusal to start medicines. Those ones who started would get lost follow-up, and those who would continue would not take medicines consistently, so they would keep interrupting treatment. And this list was generated by the main treatment center in Uganda called Mulago National Referral Hospital. On its generation, it was shared through the National TB and Leprosy Program, and it trickled down to the city authority till it reached us, who are the frontline TB control officers in the different divisions of the city. And I'm really very happy and honored to have been one of the first few personnel at the forefront of tracking and linking these most wanted MDR cases in the country. Next slide. Yes, how did we start this? Personally, I was allocated the first 19 missing cases whose documented address read Makinde Division, where I used to take charge of. And this meant that we had to prepare. Preparing involved conducting data exchange meetings with all the participating diagnostic and treatment units, and to discuss around the fate of these patients who are lost follow-up, who are missing treatment, who have failed to adhere to treatment. Also coordinated with other TB supervisors across the country to try to help us to link to these most wanted cases. And for those with complete documentation, we reached out to them either directly or through the treatment supporters, and also had physical home visits to make sure that we try to get them started on treatment. Then we also worked with the local council authorities and the village health teams to locate their homes, because Kampala is one city that has lots of congestion, so paving way through to reach them was quite difficult. So we also had details of their records extracted from their health facilities to back up all the other information that we had. Then also ensured that conducted radio talk shows, TV talk shows, such that the communities become aware of the huge burden and the consequence of not having such kind of clients started on treatment. Unfortunately, by the time, many health workers were afraid to follow up these infectious patients who had been with us actually for a very long time. Actually, the list that we had was ranging right from around 2007, 2008. So it really scared many people because these patients were deemed to be highly infectious, but we braved and moved on. The assurance that actually made us continue was the availability of medicines that were assured by the National TB Program, but also the most important thing that we had training around TB infection prevention and control. And then the other fact that what would have happened if these cases remained untreated, that one alone gave me personally a lot of confidence, and actually it propelled me to protect the most vulnerable by being part of this team. Next slide. What we did in terms of tracking, we reached out to the patients or the caretaker, agreed on place and time of meeting for those whose contacts were available, and also conducted health education to both the caretaker and the patients. Then did contact investigation for those we managed to reach physically. By contact investigation, I think that's now a very familiar word, especially because of COVID-19. I would look at the persons, would assess the symptoms among persons who lived with these patients for quite some time. Then as we did this, we ensured infection prevention and control, given that TB is airborne, mainly focusing at being in a well-ventilated area, wearing N95 respirators, and also limiting the contact time. And the patients and caretaker were immediately all taken thereafter for treatment initiation, and to depend on what actually would find on ground, because some patients you would find when they had transferred several times, so they had multiple locations. So sometimes it would be quite difficult. So on tracking, we realized that 46% were still in the same locations. 53 of these cases had long relocated, as I mentioned, and 52% were HIV positive. Thus, had dual treatment burden. 79% fortunately were reached successfully, with 74% linked to treatment, and 15% unfortunately had died. These are 3 patients. And one of the patients could not be found due to incorrect information. So this became a big problem, because missing one patient not on treatment means actually the entire population is not safe. And majority of cases were already on herbal medicines. So this brings us to thinking of how best can we handle the natural chemotherapies versus the modern medicines that we are using. So we need really to think hard around that. Then one refused treatment, claiming herbal medicines was better. So you can see the extent to which that can reach. Then some of the patients gave false information to health workers as being non-MDR, especially when they reach the MDR treatment centers before the time the first line regimen was in the country. So health workers were ignorantly and innocently treating these patients, and as either susceptible TB or sometimes as any other ordinary cough. So this also facilitated transmission. Then tracking and linkage continued, and interestingly, by 2017, Uganda had enrolled 1,311 MDR cases, and 64% of these were male, giving you a clear indication that the prevalence is much higher among men, not only for MDR, but also for susceptible TB. And over 98% had pulmonary TB, which is an infectious form of TB. TB of the lungs is quite infectious compared to other forms of TB. So that gives you the reason and the understanding why MDR TB must be avoided. Then over 2,000 MDR cases so far have been enrolled by this year, 2022. Next slide. So that gives us actually a lot of thinking around how best can we do this. So the mode of care, we can see that for us, in order for us to absorb many patients on which were on the waiting list, a DR-TB mixed model of care was conceptualized, given the history I've given you. And mixed model, we had both those ones who are they would stay on treatment for some small duration of time, 1 to 8 weeks, then thereafter transferred to the nearest peripheral DOT site. I'm glad the previous speaker from India used this kind of approach through the pharmacies and drug shops. So we also applied the same. So so the learning continued, my sister. So the other thing is that to reduce on the on this catastrophic costs associated with TB, this mode of care, the mixed model, was actually quite handy. Then also that kind of model increases the family and social support, because the patient can easily can get treatment in the nearest pharmacy, the nearest drug shop, which is very important for them to go back home, and also reduces patients' fatigue associated with moving to distant health facilities. Imagine if they have to move from a long distance facility every time to go and pick medicines. And remember, TB treatment is daily. And then we used to have a 6 months of injections. So that would mean moving daily to a far distant health facility. Then also this model builds capacity of local clinics to screen and manage MDR-TB, and also simplifies access of contacts and caregivers to the nearest health facility. Next slide. These were the core barriers to linkage and, okay, the lessons that were learned. One, drug resistance is rapidly growing, and therefore, there is need to invest more in primary prevention, including appropriate treatment of DR susceptible cases. Then, based on reported barriers to treatment, there is need to invest more in research to get highly effective, affordable regimen for shorter duration and minimal side effects. Then there is also need for local authorities and caretakers or next of kin that can enhance fast tracking of unstable patients. Then, whereas tracking information from outpost sources can lead to fairly accurate patient location, timely and complete accurate documentation is very important to make sure that we have this done. Then enablers such as food and transport are effective at retaining patients in care. However, this ought to be at a level that is sustainable, and poor quality data delay decision making. Then it's very important to do continuous capacity development to make sure that health workers get the right information. Then mixed model of treatment can potentially improve retention in care and social support, especially in resource-limited settings like ours. And finally, herbalists and churches significantly contribute to decisions made by patients, and thus need to be brought on board to end drug resistance. So mixed standards of drugs to avoid the mixing of drugs with herbal medicines. Last slide. I think these are really statistics which can be seen. Next one. Yes, those are statistics of the most recent utilization of GeneXpert. We can see GeneXpert is the latest technology that we are using across the country. So we can go to the next slide. And we can see the TB HIV cascade for the country. So we are double burdened, and therefore Uganda as a country, we need to continuously focus on both TB and HIV. So when we were speaking about TB or MDR resistance, we also need to speak about HIV resistance, because the patterns are almost the same. Go to the next slide. Yes, some of the issues we did, of course, were around training of the health workers, as demonstrated in the previous slides. And this was extremely important to teach both the health workers within facilities, but also empowering young people, both from universities. For example, the photo on your right, those are some of the students from Makerere University School of Public Health who participated in actually following up of the patients and also identifying new cases. And then other photos around the sensitization and both using the media and also reaching out to communities where they live. I thank you very much.
Thank you so much, Tadio. There are so many lessons to be learned from this really courageous and successful project that we could use to translate into some of the AMR work, especially working with that non-ideal patient and the co-administration of herbal remedies and the myths that we all have a responsibility to dispel. So I'm sure there'll be lots of questions for you, and the full slides will be on the websites. So it gives me great pleasure now to invite champion of all champions, Eric Venant, to speak. Eric is the founder of the Rollback Antimicrobial Initiative and lead coordinator of BSAC's Stop Superbugs based in Tanzania. So welcome, Eric.
Thank you very much, Claire, and it's a pleasure to join today's session. So, as we have seen today, as we are focusing on stewardship in communities, and this is one of the case study as we have been focusing on engaging communities in containing antimicrobial resistance. Next slide. So I would like to start with this quote. So Alexander Fleming foresaw some of the behaviors which might accelerate the emergence and speed of antimicrobial resistance. So the behaviors which are already accelerating the spreading of drug resistance and its emergence was also foreseen. And here in this quote, we can just see about some of the behaviors, like not completing the entire course, the entire dose, but there are so many behaviors in the community which are fueling this problem, and that's why we have to engage the community. So RB Initiative is the non-government organization in Tanzania and has been engaging the community both at rural and urban communities, seeing them as critical players in addressing AMR. Next slide. Yeah, and the focus has been promoting the rational use of antimicrobials and also promoting positive behavioral change regarding the antimicrobial use and antimicrobial resistance, as well as in the area of IPC WASH, and also disseminating the knowledge of antimicrobial resistance. Next slide. And these are some of key stakeholders we have been working with, including the general public, the schools, colleges and universities, policymakers, as well as local leaders and healthcare workers. Next slide. So why engaging community in tackling antimicrobial resistance? So we all know that AMR affects everyone at any age and any country. So it's really critical also to engage the community as we take different interventions in combating antimicrobial resistance, but also the actions taken by individuals, the families and communities are key to contain antimicrobial resistance. Some of the behaviors like sharing of antibiotics, like self-medications, all these are starting from the individuals, from the families. So it's very critical to engage the community in tackling antimicrobial resistance. But what's very important here, it's considering the local context while engaging the community in tackling antimicrobial resistance, because it's every community has its own context, has its own culture. So it's very important to consider the local context. Next slide. Yeah, so here you can see these are the different groups in the communities which have been engaging, and these include the local leaders, the influencers at the local level, also through the use of local radios to disseminate the AMR messages and also promote the behavioral change, and also through the use of road shows in the streets, and also different adapted or tailored workshops at the community level. Next. So I'll be having two focuses as case studies. And one of the area we've been focusing is engaging the school children as agents of change in containing antimicrobial resistance. So as we know, one of the strategic objectives for the Global Action Plan and for the most of the national action plans is to improve public awareness and understanding of AMR. So we have been engaging the school children, empowering them and developing them as agents of change so that they can be able to communicate about AMR to their families, at their communities, and also themselves are also future agents of change, future parents, and also future policymakers. So we have been like pioneering the use of youth as change makers in the communities. Next slide. Yeah, so through the AMR school clubs, we have been using different methodologies, and one of the key issue here is the use of arts and crafts in communicating antimicrobial resistance. As we all know that AMR is very complex. Now, communicating it, especially to the young generation, we have to be to use different methodologies. So here we have been using different methodologies, especially the arts and the crafts, like the use of songs, skits, drama, and set of funny activities, storytelling, to make sure that these messages are communicated in a fun way, but also they can be understandable and communicated to the community level. And also topics include like behaviors that accelerates AMR, hygiene and sanitation, and the impact of factors and sensitizing in the One Health approach. And this also goes hand in hand, also engaging the parents through tailored workshops, as well as competitions on antimicrobial resistance. Next slide. So here you can see these are the trained AMR champions using the Swahili songs to raise AMR awareness. And these are the trained AMR champions using a drama to raise the AMR awareness. So they learn this in a simple and fun way, and then they're able to communicate the messages to the community and also to their families through the use of simple language and considering the local context. Next. Yeah, and here you can see these are the use of traditional dances to raise awareness on AMR and promoting behaviors like health-seeking behaviors, and also the relational use of antibiotics, especially using antibiotics without prescriptions, as well as the key role of hand hygiene in spreading the infections. So these are just learning and using the traditional dances to be able to communicate with different groups in the populations, considering the different levels, the different needs, the language, and also the education level. Next slide. And then this is the engagement. Here you can see the engagement of the tailored workshops to engage the parents and the community members. And here the trained AMR champions also was getting the chance to communicate the messages through the arts and the crafts, and also to explore some of the common behaviors from the community members, from the parents, and how we can both work together to mitigate those behaviors or to slow down the spread of antimicrobial resistance. So engaging them, engaging the community is very critical. And these are the empowered change makers after finishing the training, and then we're developing them as ambassadors, and we keep tracing them, and they keep spreading the messages. Next slide. Yeah, so one of the challenge, or one of the content has been educating the school children about hand hygiene and sanitation. But one of the challenges has been the practical support, the hand and hygiene and washing infrastructures. So we adopted the AMR Arts and Craft competition. And for the winning school, we're just encouraging them, and as part of the practical support, we're trying to support the hand washing infrastructures, but also as the further motivation for participation and to put into practice what they're learning. Next slide. This you can see these are some of the hand washing infrastructures. So as part of the practical support, but also this is a motivation for the arts and the craft competition, and motivating the school children to be very creative and coming out with different arts and the craft, like the songs and the dramas, to make sure they are really motivated to participate further. Next slide. And we also conducted the CAP study before and after the training, and we investigated in some of the behaviors, like the use of antibiotics to treat the flu, and the knowledge on the practices and the behaviors that contribute to AMR, as well as the knowledge on the consequences of AMR. And after the interventions, the knowledge increased above 90%. And that was a good thing for them. And we assure that they keep using as they keep sharing the messages and working as agents of change in their population. Next slide. So my next session is my next focus is the World Antimicrobial Awareness Week, and this is because we are around the World Antimicrobial Awareness Week. So it may be late, but you can be able to get some insights on what can also be planned next year as part of engaging the community in containing antimicrobial resistance. Next slide. So these are the three-wheeled motorcycles. I think in most of the countries, for example, in Asia, like India and Thailand, they are being used as part of public transport, as well as in most of the countries, sub-Saharan Africa. So for example, during the World Antimicrobial Awareness Week, we have been drafted the adapted messages and then train the drivers and then put the adverts with key AMR messages in these means of public transport to communicate some of the AMR messages to the whole, to the general population, but you also training different groups, for example, the drivers to be able to disseminate the flyers and also to understand what AMR is. And this is very important, especially when we want to make sure that everyone has a role in containing antimicrobial resistance. Next slide. And this is like the training for different groups, including the journalists, including the drivers, and also including the influential people at the community level, like the local leaders. So all these are some of the key groups to engage if we really want to promote behavioral change and also to increase the awareness about antimicrobial resistance at the community level. Next slide, please. Yeah, so you can type in the chat as I'm going to finish my presentation soon. But what activities could be implemented during the Antimicrobial Awareness Week? Not this year, of course, because it's just around the corner, but maybe in 2023. You can identify different groups you can engage in your community. And then these are important considerations when addressing AMR. And here to emphasize, it's very important to translate the global action plans, and also the national actions plans to the local context. So the communication messages must be customized according to the audience characteristics, as well as considering the audience who is no formal medical education, and also selecting different communication channels which can have an influence in a particular community, like the local radios and etc. Next. Yeah, and these are some of the challenges and some of the proposed solutions. So one of the challenge was limited knowledge and awareness about AMR by the community, and here meaningful engagement of different groups, as we have seen, but also the community influencers as a key important in making sure that we spread this. And also the outcome measurement, then is here you can be able to divide the activities, those which can be measured and those which cannot be measured, and always conducting the baseline and the end-to-end surveys has been useful. And also the limited funds of patients to buy full course. Here it's about taking into consideration the social determinants of health, and sometimes people cannot be able to afford buying the full course of antibiotics, for example. So I think here it's very important also to explain the cost impact of developing the resistant infections, and also the funding to run the effective campaigns. Next, last slide. And finally, these are some of the takeaways. One Health approach, including both sectors, the environment, the animal, and the human. And that has been a focus of this year's also our theme, working closely as a multi-sector partnership, and also remembering that simple measures like awareness raising are feasible and effective, and a plan to the World Antimicrobial Awareness Week activities and beyond that. And also use recognizable health events to also communicate for AMR. Like we have malaria days, HIV days, and those days. And also adapting to the local context is critical in addressing antimicrobial resistance. Thank you very much.
Thank you so much, Eric. I think we could all listen to you all day, but I apologise that we have gone over schedule today. I would like to introduce our last speaker, who is certainly not least, Dr. David Musoke, who is a senior lecturer at Makerere University School of Public Health. I've had the great privilege of working firsthand with David and his phenomenal team, whose efforts we'll now hear about, if you're okay to stay on. Thank you so much.
Thank you very much, Claire. And I know our time is fast spent. I'll endeavor to stick within 10 minutes so that we can end this session as soon as possible. And I'll be very pleased to share with you some of the work we've done in Uganda on antimicrobial stewardship, mainly looking at the training of trainers approach in ensuring that our community health workers in the country are enhanced in terms of their knowledge on AMS as part of our partnership with Nottingham Trent University. So just to introduce this to the audience quickly. So we have this partnership between Nottingham Trent University and Makerere University that has been in existence for over 10 years. And recently we were able to link up with colleagues at Buckinghamshire Healthcare NHS Trust to really target the CW PAMS scheme. And we've been able to do some work in Wakiso in Uganda, looking at various levels of the health system, health facilities, community, as well as the university. But we've been able to take a One Health approach, which is, as you've heard before, looking at both human health, animal health, and the environment. And a team that we are working with, as you can see, is quite multidisciplinary, involving pharmacists, microbiologists, and other professionals, as you can see. And we found this to be a very interesting approach, whereby both the animal health and human health practitioners learn from each other. And indeed, the experiences are worth sharing while in these workshops, which involve groups from both sides of the health sector. So for those who may not know, community health workers are a cadre of human resources for health that does a lot of work, particularly in low and middle income countries. In the Ugandan context, they are called village health teams. And their roles include treating childhood illnesses, carrying out health education, mobilizing the communities for various public health interventions, including vaccination, including distribution of mosquito nets. Most recently, they've supported the COVID-19 response. And as we speak, they are also engaged in the Ebola response in the country. So they're actually a critical resource in our setting. And therefore, some of our work in Uganda has really focused on them over the past so many years. As part of our CWPAM's work, together with Nottingham Trent University and Buckinghamshire Healthcare NHS Trust, we've been training health practitioners using a One Health approach. This includes health practitioners from health facilities. We've also had animal health workers, including veterinary officers and other cadres. But most recently, we've also trained community pharmacists, or in the local context, we call them staff from private pharmacies, because these include pharmacists, but also other health cadres who work in these settings, including nurses, midwives, pharmacy technicians, and so on. So this slide just shares with you some of the main topics we have been training among these people. And this training has been led by our colleagues in the UK, of course, with the support of our Ugandan pharmacists and other professionals. But as one of the topics we've had included in these trainings is really increasing awareness on AMS and AMR. And as many of you would know, whereas the health practitioners do a lot of sensitization at facility level, we felt that having an approach which goes beyond facilities into the communities would have a big impact. So as part of this particular training, we were able to have a session on the health practitioners designing messages, but also how they can be acquainted with the needs of the community health workers, so that after the training, they can go ahead and pass on the learning and the lessons to the community health workers, who in our context are volunteers. And we found this to be a very good approach, because remember, the community health workers reach more people in the community, and they are closer to the population than health practitioners who are based in pharmacies or at hospitals. So this training of trainers approach we felt was important, because the few health practitioners trained are able to reach even more community health workers who are able to spread the word and do much more concerning increasing awareness on antimicrobial stewardship. So as part of the training of trainers approach, they trained health practitioners, including pharmacists, including nurses, including clinicians, have been supported to train community health workers in this district in central Uganda. And this slide just shows you some of the topics that have been trained by the health practitioners among the community health workers. And this approach has really been instrumental in a way that, whereas the UK team has supported the training of the higher level health practitioners, the health practitioners trained have been able to reach to many more volunteers in our local context called village health teams. We've trained close to 200 health practitioners at the higher level, but these have been able to train over 400 community health workers, and the number is still growing. And the UK team has not been involved in any way in directly training these volunteers. These volunteers have been trained primarily by the trained health workers, the pharmacists and the others. And we believe that this approach ensures that the knowledge gained by the health practitioners does not end at them, but they're able to train other cadres who are also able to reach out to other members of the community as we increase awareness on AMR and try to improve antimicrobial stewardship. So as part of these trainings, we are able to carry out pre and post-training assessments, as many other partnerships do. And I'm highlighting one particular question that we've been able to assess among the community workers, where we ask them whether they feel they are knowledgeable enough before and after the training in terms of educating the community they serve on proper use of medicine. And as you can see, at the start of the training, not very many felt they were confident enough and knowledgeable to educate their communities on proper use of antimicrobials. But at the end of the training, you can see all the volunteers expressed confidence that indeed they could go out and educate their communities. We carried out a project evaluation about 3 months after the training, and we found that many of the trained community workers had reached to over 100 individuals and educated them on proper use of medicines. And this was just 3 months after the training. If we evaluate probably a longer time beyond the training, we may find that probably even more people have been reached. And I believe that these people who are reached may not have been reached by the health practitioners who were trained earlier as part of this work. So you can see that this approach ensures the knowledge is moved to lower levels of the health system. So our key lessons from this particular work is that indeed health practitioners trained on antimicrobial resistance and stewardship can pass on those skills to other members of the health workforce. In our setting, of course, these community workers are instrumental, and indeed that has been quite interesting and a big part of our work. But also from what we have realized that having community workers engaged and involved in the whole AMR and AMS activity ensures that the wider community is reached. There are some people who may never get to a health facility or to a pharmacy to be educated by a pharmacist on proper use of medicine. But if you have these community workers who are closer to the community, trained and their capacity enhanced, I can promise you, you're going to reach to more people in the community and probably will have more people carry out ideal practices. But also to emphasize that this approach is feasible once the health practitioners are oriented on how they can engage other cadres, they can do so. And once they do so, for sure, the impact will be more than if we were to focus only on the higher level of the health workforce, that is the nurses, doctors, the pharmacists, and the others of the kind. So I just wish to acknowledge the various partners who have supported this work. Of course, the funders, the UK government, DHSC, Fleming Fund, CPA and FED, but also the main partners in the UK and Uganda, Nottingham, Trent, Makerere, BHT as we call it, but also the local partners, Ministry of Health, Interior General Hospital, and the other stakeholders that we have participated in. Of course, with more time, we could engage and discuss this further. Otherwise, thank you again for attending the webinar, and I'll hand over back to the chair of the session. Thank you very much.
Thank you so much to everybody who has stayed online for this session. I know that we've gone way over time, but I think it's such important work that we've been hearing and sharing from each other. So thank you. I just want to say, Dalia, would you like to say a few words, please?
Thank you so much, Claire. And again, thank you for those that have stayed behind for the extra 10, 15 minutes with us. Wow. This was really inspiring and definitely motivating for all of us to learn about all the different and various initiatives to really advance the agenda on AMR and AMS. Thank you, our previous speakers, for all of these hints and good practices that I'm sure will be very useful to the audience and lessons learned to all of us. Claire, considering that time constraints are tight, I'd like us to perhaps proceed with closing the webinar if you have no further remarks. And we definitely encourage our listeners to send us any questions, any outstanding questions by email as presented in the chat box. But we would like to also remind our listeners that the next session on AMS is going to be on the 18th of November, and please do join us. The registration link will appear in the chat box, but also is available on our website. Thanks a million, everyone. And thank you all for attending. Thank you, Claire. Thank you, CPA. Thank you, guests, for being with us today. Really appreciated all of the information sharing and lessons learned. Have a good afternoon, night, day, everybody. Thanks a million.
Thank you so much, everyone. Really great to have such a good turnout of everybody. And thank you especially to Ali and Nikki, who have coordinated this event. So very grateful to all our speakers, as Dalia said. Hope to catch up with you at the next one. Take care. Bye.